Good afternoon, and welcome back to the Health Leaders, the Winning Edge program, a weekly series of webinars touching on the topics and strategies that you need to know most. My name is Chris Cheney. I am the CMO editor for Health Leaders and will serve as your moderator for this session. Today's webinar is titled The Winning Edge for Strengthening Physician Engagement and Clinical Efficiency, sponsored by QGenda. Thank you to our sponsor for making today's program possible, and to you and our audience for participating. Before we get started, and for those of you participating in the live program, I have a few housekeeping details. Note that an on-demand version of this program will be available on our YouTube channel on Friday and can be accessed through our website, healthleadersmedia.com. To ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Next, you will find a resources list for today's webinar on the upper right of your screen. Here we have listed the webinar slide deck and some additional materials for you to download, along with a registration link for future Winning Edge events. At the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our panelists for today's discussion. Andy Anderson, Executive Vice President and Chief Medical and Chief Quality Officer for RWJBarnabas Health. Tom Balsazak, Chief Clinical Officer at Yale New Haven Health. Patrick Hunt, Chief Medical Officer at QGenda and Chief Medical Officer for Acute Care at Prisma Health. And Ghazala Sharif, Corporate Executive Vice President and Chief Medical and Operations Officer for Acute Care at Scripps Health. Thank you all for joining us today. And with that, let's get into our discussion. First, please tell me a little, or tell the audience a little bit about yourself and your organization. And Andy, why don't you go first?
Thanks, Chris. I'm a physician, a general internist by training, have worked as a hospitalist and also still do a little bit of primary care. In my organization, RWJBarnabas Health, I'm responsible for quality, safety, patient experience, and our relationship with Rutgers related to our academic mission with research and medical education. RWJBarnabas Health is the largest academic health system in New Jersey with adult and pediatric and the full spectrum of services in the hospital and ambulatory setting. Thank you, Chris.
Great. Tom?
Hi, thanks, Chris. Tom Balsazak, I'm the Chief Clinical Officer for Yale New Haven Health. We're located in New Haven, Connecticut, and the health system sort of spans the coastline from the New York border into New York through Rhode Island. In my role as Chief Clinical Officer, I have the CMOs, the acute care hospitals, and quality and safety, and a number of other responsibilities, very similar to other Chief Clinical Officers that I'm sure aware of in other large health systems in the United States.
Excellent. Patrick?
Thanks, Chris. So Pat Hunt, I'm the Chief Medical Officer for Acute Care at Prisma Health, so in charge of anesthesia, radiology, hospital medicine, emergency medicine, and pathology, and some critical care. We're a 12 acute care hospital system in South Carolina and Tennessee. My software life, I founded a company called Shift Admin, scheduling software for the acute care space, and it's acquired by QGenda. And I function as the Chief Medical Officer for QGenda, and then I've started working as an advisor for an ambient AI company, Clio Health, in the acute care space as well.
Great. Ghazala?
Hi, Ghazala Sharif. I have an unusual title, Chief Medical and Operations Officer at Emergency Medicine and Pediatric Emergency Medicine physician by training. I have 5 hospitals but I also do quality patient experience, but I also have a responsibility for the finances, hence the chief operating officer role for the 5 hospitals. So I have information services, support services, pharmacy, and the chief executives across the hospitals reporting to me. So it's an unusual role in that typically you don't have a chief medical and operations officer be the same person. But as we talk more today, you'll see how that structure works very well at removing barriers and moving things faster in our journey.
Let's get into our discussion. What are the primary strategies for effectively communicating with medical staff in clinical care scenarios, such as in time-critical situations and otherwise? And Andy, why don't you start us off?
Great. So I want to emphasize the importance of picking up the phone and having a direct conversation in those most urgent situations in particular, but just in general, I don't think we do enough of that. Outside of that, there are ways to communicate that are less real time, like through our electronic health record. There's a chat function, so certainly that is another means, or texting each other. The other opportunity that we've utilized fairly well is the alert system related to sepsis and or deterioration, things like someone at risk of dying. We have an alert system where we can use that to send out sort of a mass text, I'll call it, to have folks know that there's an issue brewing and provide them with real-time data so they understand sort of the basis for the issue. So that's another means. And then finally, just a comment about the importance of the physician-nursing partnership and really making sure that our doctors and our nurses are talking to each other and communicating about the plan of care, getting to know each other so that when things do start to go in the wrong direction, there's an easiness, if you will, for them to pick up the phone and talk to each other.
Andy, if I could ask a question. So what tool are you using to send that? It sounds like sort of a care team alert for like septic patients. Are you doing that through the EMR or another tool?
We're on Epic as our electronic health record, and we're doing it through the EMR. Yeah.
Okay.
Tom, you want to go next?
Sure. I mean, I agree with everything that was said prior, and I would say that I guess the strategy really I would sum up by saying it's sort of multimodal. As an organization, we have both a large geography and it's a dispersed geography across a long distance, which can make communication hard, but it's also a 24/7 operation like all health systems are. And so you really need multimodal strategies to get out the word. And we will do everything that was just mentioned. We also will push things to via secure chat or other ways that clinicians have on their phones. We'll send email, which seems so 19th century at this point. But we also will use our electronic medical record screensaver scene, which we call Net Presenter, because whenever any of the computers in any of our areas across the health system go to the screensaver, we have the ability to use that as a sort of a billboard, if you will, and present things that way. It depends on the nature of the issue, whether it's acute, subacute, what have you. And each one of those strategies, I think, needs to be appropriately utilized, for the time frame that you're trying to get things out.
And Pat.
Yeah. So, I mean, I agree with both what Tom and Andy said. And I sort of reemphasize, Andy, the concept of picking up the phone and having conversations. I think over the last 10 or 15 years, we have moved so much to the sort of electronic communication and messaging and so forth, which is fantastic and great for efficiency, but you lose some of the sort of the subtleties that you get with the direct communication lines. So I'm a huge fan of that, maybe even as an adjunct. And part of that for us has been, we had Perfect Serve for a while, we're moving to Epic Chat, but having sort of the information that I need, like, okay, how do I call, the cardiothoracic surgeon? Do I have a number? Making sure that I've got all that information so that I can have those critical conversations has been really helpful, because in those time critical situations, you don't have time to be hunting around and figuring that out. But I will say the advent of the secure chat and the ClinCom tools has been a game changer for us in terms of efficiency and the way we operate within our care teams. It's really been very helpful for us.
Excellent. What part does your medical staff play in driving efficiency and cost savings? And Tom, why don't you go first?
Hey, Chris, can I chime in on the last question real quick?
Oh, yeah, sure. Go for it.
Yeah, that's all right. In addition to what everybody else said, we do have the best practice alerts, BPAs, and we've been very careful about that because we don't want to ping people all day long so that they disregard the BPA, the best practice alert. But we have found it very successful in sepsis patients, example, because that's something that we are dinged on by CMS. And also just recently, we're looking at telemetry utilization. So at a 48-hour mark, we say, you sure your patient still needs to be on telemetry? Because sometimes, as this team will know, you put somebody in telemetry and you keep them on forever and ever. And that is a lot of work that we have to do to replace patients. So simple things like that also help. We also have a chief of staff morning tea. I just finished that this morning, where we build a relationship amongst the hospital. So it's a lot easier to pick up the phone when you have that comfort with each other and with our physician operating executives as well. So all the standard stuff that the team talked about with secure chat, but going a level deeper. We unfortunately were hit by a cyber attack that still gives us PTSD, even though it was about 4 years ago, but we have a secure text stream as well if we need to, then we can activate that. And a program called Everbridge, which if everything goes down, we can communicate key information through the app. And so that's something that's been a game changer for us when there's earthquakes or anything that happens in California. We're able to communicate. We have fires recently. We're able to send out alerts about smoke in the area, things like that to people that are affected. So a different modality for communicating other clinical scenarios that are going out in the community as well.
Great. Sorry, I skipped you there,
Right.
Gisela. So going on to the next question, what part does your medical staff play in driving efficiency and cost savings? And Tom, why don't you go first?
Sure, Chris. Thank you. I think, they play a critical and increasing part is what I would say. We used to, years ago, say the most expensive part of healthcare was the physician's pen. Now I just think it's the enter key or the mouse, because everything that happens to and with patients happens and is driven through what choices the physicians make. And the physician's choice is so unbelievably important in both efficiency and savings, as well as quality and safety and all of the outcomes that we are expecting. I think the thing that's really critical here is how do we tap in to the physician's knowledge base in order to figure out where we might have opportunities for efficiency and cost savings. And we are surrounded and have a richness in number and experiences of physicians, and we've tapped into that in a way that that we're calling care signature. And about 5 years ago, we kicked off our care signature work, where we embarked on something that sounds like it's fresh out of the 1980s, which are care pathways, and building them into our electronic medical record with an overlay that allows physicians to have at their fingertips real-time knowledge about choices they may make around drug ordering or test selection, et cetera, and gives them real-time feedback on if what they're doing is the most efficient, cost-effective, and efficacious way to practice. So this care signature work, where we have an overlay on top of our Epic electronic medical record that gives them actions and suggestions with regard to order sets, I think it skips over those kinds of things that we all dislike, which are hard stops in Epic or BPAs that flash that physicians tend to blow right through. And instead gives them an opportunity for real-time knowledge at their fingertips for the challenges that they're facing. In addition to that, which is really every physician and at every encounter, of course, there are also larger, I would say, more, CFO-focused kinds of initiatives that we work on. I think everyone is looking at their pharmacy formulary and their purchase on implantable devices and so forth. And we have the same sorts of work going on with that as most health systems across the United States do. I would say that, with regard to that, it's really important to get folks that are key influence driving physicians in our organization, and then give them the structures and processes in order to drive towards the most efficient way of delivering care. Early on, we many years ago closed our pharmacy formulary and then created an equivalency in biosimilars, for example, so that the pharmacy was free to go out and negotiate best price. It seems like it seems unbelievable that 25 years ago we had an open pharmacy formulary, for example, and then that's just one example of where we've used the knowledge in I think skill sets of the physicians to try to drive towards the best possible answer for our patients while also driving towards efficiency.
Excellent. Patrick?
Yeah, so I mean, I agree and echo all the stuff that Tom said. I think, when I think of it, the most expensive resource that, pretty much any facility has is its providers and the expense that we write for their, the work that they do. So for us, it's been really optimizing our scheduling, so forth, so that we're utilizing our providers appropriately, and then also our space appropriately. So, if we have clinic space that we can use more efficiently, we work to do that. Also all the things that Tom mentioned in terms of pathways and trying to be good stewards of the resources we have and say, hey, we don't really need to use this drug that's X, a factor of X over this drug, which also works just as well. And sometimes, we get a fair amount of pushback from providers that want to use the latest and greatest, but really trying to find those savings where you really are not impacting patient care has made some pretty substantial impacts on our organization. And we've had a big turn in the last 3 years just with using those kind of tools and resources and getting our margins moving in the right direction. The other thing that I would add to that too, which has been maybe our biggest piece, is kind of getting our medical staff to focus on access, because it does two things. One, provides access to the patients that are there looking for us, but also helps drive revenue to the organization. So working with our teams to be good stewards of their time, to make sure that we have slots for patients that need to be seen.
And Ghazala?
Yeah, in addition to what my colleague said here, we actually have a different process in place because we want to make sure that the physicians are working very closely with the nursing staff and people at the front line who are actually doing the work. And so we have what we call sprint teams when we identify an issue, such as increase in central line infections, and we put the team together and look at throughput and how do we make it go faster. ER doc, as I said, so we don't want stickies on the wall and go round and round in a circle. But it's important for the physicians to work directly with our staff on some of these issues. What we do have is service lines as well, and so we rely on our physician leaders to bring products to us, and then we have what's called a medical effectiveness review committee. And I think it was you, Patrick, that mentioned sometimes, or Tom, one of you, physicians may want another, skin graft because, the vendor has brought it in, and we actually bubble that up to a medical effectiveness review committee to say, is it really something that we need, or is it something that you just want, it's a Me Too thing that you want to have, and does it really change the outcome? And so we have multiple different ways to make sure that we are actually not only driving efficiency, but really getting the cost savings. And having those service line physicians speak with the vendors directly is huge. It's way different than having your supply chain do the negotiations. When you have a physician, right, who is using the striker, they are more likely to be able to get a deal for us than somebody else. And so we've kind of sent them out there in that world to help us. And the other thing that we do, we just started 2 years ago, is a different capital planning process. Otherwise, we were getting requests all over the place for this and that, and the physicians couldn't understand why we couldn't give them what they wanted. And so now, with my role as our CMO and operations officer, we actually have the physicians involved in the capital planning early, so they know what the budget looks like. They are actually helping me prioritize, okay, we need the cath lab in the south. Okay, let's wait on the new Da Vinci robot in the other area so that we can accommodate. And so there's much more visibility into what the budget looks like, where the priorities are as a system versus each hospital trying to rally and get the budget themselves. So that's a process we just put in 2 years ago. We're finishing it up for this year. And they actually understand when you explain it to them and lay it out. People talk about being transparent. I always think it's opaque unless you open the books freely. and let the physicians know what the budget looks like and why we're spending what we're spending. And it's actually settled everybody out. The answer may not be the answer they want when we say, sorry, you can't have it right now, but here's the why. And it's working really, really well with our, especially with the budgets the way they are in the country. We're gearing up for cuts that are coming. Again, having the physicians involved early in those conversations to see what services do we need to do, what might we need to sunset. So many different avenues for involving our physicians in the process.
Excellent. Andy?
Just a couple of things to add. First, I love that you have physicians, at the table making those really big decisions. That probably plays into your combined operations role. It makes complete sense. Love that. I would just say generally, just state the obvious, we all have a duty to be stewards of healthcare resources, and it ties into the value equation, the triple aim, quadruple aim, quintuple aim. It's part of what we all should be thinking about as leaders and as frontline physicians. And as I think everyone has said, engaging physicians in this work is the trick, is the most important part of it. We've done a lot of work on lab testing stewardship, medication stewardship, and I'll call it physician preference item stewardship. So orthopedics, cardiovascular, neuro, et cetera. And in each of those instances, we have physicians at the table, mostly, leading the conversation and helping to identify, opportunities for the health system. And the other really big part of this, I think, is transparency and just sharing information. Most physicians just don't know how much things cost or what the options are, and really just being very transparent and saying exactly what these things cost. It creates energy and competition, if you will, to try to get the best price. And so it really can be quite engaging.
Anything else before we move on? Great. What are the primary care team communication strategies to help drive quality and patient safety improvements? And Pat, why don't you start us off?
Yeah, so I think we've talked on this already a little bit. I think we all use similar, alerting systems, PPAs, whatever we want to call them, to try and drive those notifications. Because a lot of it, again, it's about communicating with the providers and the nurses when things sort of are hitting these stages of this patient's getting sicker, we're having a change in vital signs. How are we going to do that? So having those systems in place in some way, shape, or form is important. And the flip side, which was also mentioned, is doing it only when it's really necessary. It got to a point early on when our EMR was up that we had, you'd get 10 alerts on a patient, and none of them really mattered, to the point where it's sort of like alarm fatigue in the emergency department. It's like you get 25,000 beeps coming on, and the one that you really need to pay attention to, you don't get. So you have to be very, very selective about what tool you use and how often that tool fires to get the bang for the buck. And so in our instance, it's been a continual balancing act to try and figure out what's really important, and then what are the things that we can do that are maybe a little less intrusive, with just something maybe in the EMR, whether we change the color of a name, or we change the color of a lab test to do that. So any of those kind of things that you can do that flag without causing a significant disruption, and maybe most importantly, requiring an additional set of clicks, because the click count, while, it's the death, one click, but it's the death of 1,000 clicks. And by the time you've had to click 1,000 times, you've spent an inordinate amount of time just clicking things on the computer, not actually taking care of the patients.
Great. Ghazala, you want to go next?
Yeah, to tag on to that, we talked a little about in-time communication, but I mentioned very briefly earlier our sprint team concept. And so we have a physician on every one of those teams, and that's really important. It's different than me saying you need to, take your urinary catheter out earlier, or why you're sending a culture in the first place on end-of-life patients. It's different for me to say it versus somebody who's actually doing the work at the bedside. And so we have at each site a physician lead, depending on what we're working on. We also have to make sure that the documentation is correct. What we have found through many different organizations that we have to report to, like NHSN, National Health and Safety Network, that if we don't document the quality of the work that we're doing, there's a financial penalty on the other side of things. So we have a clinician advisor at each of our hospitals to help to make sure that we are documenting what we're doing in real time to drive the quality and really the patient safety improvements as well. So it's a little different than just regular communication, but it's constant feedback and closing that circle every time and moving quickly on things that we need to move on. So I think you've got to have a physician leader at every one of these meetings. Otherwise, it'll just spread, round and round we go. We never get anything done. And that model has been really successful. Sprint, and then if you need to keep going because catheter-associated urinary tract infections are not ever going to get to zero, then we have a task force around that as well. And having a physician lead, I cannot emphasize that at each of the hospitals, depending on what you're working on. And that just ripples through medical executive committee to the frontline leaders much, much faster than me just sending them an email and telling them this is what they need to do.
Excellent. Andy?
A couple of things to reinforce. The data for me is critically important, and communicating the data in a very predictable way. And the data needs to be actionable, it needs to be transparent, it needs to be timely. And then along with that comes a sense of competitiveness, that you're being compared to your peers, you're being compared to national benchmarks, and it does help drive mindset of getting better when you see your data and you know how you're doing compared to others. The other piece of it is being clear about how this impacts reimbursement from payers. Value-based payment, pay for performance, making sure that the primary care teams understand there's real dollars tied to these outcomes, and really helping them understand what those are and how we can get to a better place in terms of our reimbursements.
And Tom?
Yeah, I've been sitting here listening. This sounds like a master class on communication, and I agree with everything my colleague said. I would, not to add anything to what they've said, I would just take a different tact, because I think in addition to everything that was said, I'm thinking of that George Bernard Shaw quote that, the single greatest delusion about communication or the single greatest concern about communication is the illusion that it has occurred, or something along those lines, which is you really need to be on message and repeat the message over and over and over again. But even before that, I think it's really important, given all the things we just discussed and all the modalities in which to drive it, is that you're selecting the things you're trying to communicate, meaning the goals and targets, carefully. You're scoping them in a way that's rational and reasonable. You're making sure that you're setting goals in a way that are also reachable but aspirational, and that they're meaningful to both the clinicians and hopefully for the outcomes for the patients. And then you're parsing them to the individual unit or work team in a way that's meaningful to them. So, it has to be meaningful, and you have to really make sure that you're doing all the multimodal kind of communications we just talked about, and stay on message around things that actually are meaningful and not noise. And that's, I think, the challenge, which is there's so much going on in so many domains of every individual's lives, even simply just within the healthcare environment, that, it's hard to separate out what is the absolutely must know versus nice to know. And, it's the old adage of if everything's important, nothing is. So you got to be very careful about what you're selecting as that message, and then how you're setting targets around it and then communicating that.
The second part of this question, what strategies have you implemented around connectivity, clinical communication, and workforce data management? And Ghazala, why don't you start us off?
You gave me the hard question. I think we've talked about some of this about connectivity. We're always trying to make sure that people, actually the opposite, that the physician takes some time off as well. We are so connected and charting after hours. We actually are looking at physicians who are up, who are not hospitalists, but who are up at 2. We have a way to look through Epic, who's on their computer at 2 a.m. working and charting, and so that we can have them be more efficient. This whole concept of work-life balance it's a confusing one to me. I call it work-life integration. Because I never felt like I'm in balance, and I wish I'd learned that terminology a long time ago. But we have to help our physicians find that. So we are doing a lot of work around how do we minimize the screen time, and some of the docs are calling it, let's get more pajama time in, so that we can actually have our physicians feel refreshed, when they come to work, versus charting for hours and hours literally after work. So that's a lot of work that we are doing. We identify those physicians. We send out a physician. We have one physician who's in charge of just data collection at each of the sites. They work very closely with our chief information officer, so we can deploy them and then give some elbow support. I think, Andy, you mentioned data. You're absolutely right. Physicians are very competitive. And so, but you have to make a dashboard that's meaningful, right? I saw dashboards, I had no idea what they were talking about, and turned my, radar off, and I didn't want any part of it. So having us design the dashboard that's important to us and the metrics, and presenting that to physicians in a way that makes sense is so critical. And we're always going to get that comment, well, it's not statistically significant, and my patients are sicker than your patients. But when you have a physician explaining to another physician why this is directional, and even if you have 5 patients telling you that you're horrible for whatever reason, take whatever that information is, and maybe I can help you do something a little differently. That's been a hurdle that we're able to overcome with the whole data statistically significant part, by having a physician in those roles. And so that's how we kind of manage how we spread the data, by having a physician review it really at the front end of it to make sure that it's meaningful.
Andy?
Just to add another word about data, and I'll call it sort of data integrity, and knowing what the source of truth is, and having a single place as much as possible to go to make it easier to find the data. So we use Tableau as our outcomes dashboard, source of truth. And that's helpful. It prevents people from sort of shopping around, looking in different places. Not that people still won't do that, but everyone knows that this is the place to go to really make sure that you're getting the most accurate snapshot in time of performance. And so making it simpler, making it very transparent about this is the source of truth for data, I think is quite important.
And Tom?
I agree with all that. I think single source of truth is important. I think, breaking it down into individual, work units to whatever possible ability you have to do that. So they're not seeing the roll-up number that they may not feel that they can contribute to, but one that's more relevant to their work unit, area, size, unit, what have you. And then, we've focused a lot on some of the high-tech ways to communicate. We also use Tableau. We also use secure chat. We also put things on the net presenter that I talked about, or use, some of the Epic welcome screens and things. But we also have these things called care signature boards, which are literally dry erase whiteboards on each unit. Very old school, very analog. And I think that, that's because I think different people have different learning styles. They pay attention to different things. And I think you have to embrace all of that. I don't think there's one single way of doing it right. I think and the only thing I would say about that is that if it's a single way, you're doing it wrong. And I think you need to do it in multiple different ways for multiple different audiences.
Yeah, what Tom said was really important about cascading data. For example, we have system goals that cascade to the hospital, which cascade to the hospital units. And that makes it more actionable when it applies to your specific unit, for example, for people to be able to do something with it and improve.
Yeah, I agree. I love the whiteboard piece. We sort of did something similar at our organization. To your point, we get so much on the electronic side that's pushed. Having another method is key. I think the other thing that we've done in terms of that's really important when we talk about single source of truth is just from a sort of a scheduling and on call, having a single location, so we know one place where we can always look and that's correct, versus what we originally had with a lot of disparate systems. And we would, you try and call somebody out of the ED and like, no, I'm not on call. I switched last Tuesday with John because I'm on vacation. And so that's been a huge help for us in streamlining kind of our process.
Yeah, we use the single source of truth terminology as well. At least growing up as a physician, we used to love to sit around and debate the most recent paper and why the data was right or wrong. And I find that has infected many of my colleagues throughout the years. And, instead of spending time on why the data may be right or wrong, I think we need to decide how we're going to change in order to improve it. And I think when you have a single source of truth with a single set of numbers, I think it cuts through a lot of that inclination that I have, many of us have, to try to argue about why the risk adjustment is wrong, the data start and stop points were incorrect, the collection methodology wasn't accurate, what have you. And you know, it gets towards, well, what are we going to do about it and make things better for our patients?
Anything else before we move on? Okay, next question. How do you engage physicians in strategy and technology decisions? And Andy, why don't you go first?
Well, similar to as we've talked through all of this, the physician input, the physician engagement is critically important. And you know, part of this is you ask, you know, what are the pain points, and you try to find solutions, technology-based solutions that are going to help relieve some of the pain points. Another really important way to do this is to engage physicians in pilots. For example, we were looking at 2 ambient voice recognition platforms, and we were piloting them both. And there are physicians involved, and they're going to help make the decision about the long-term strategy. So you pull physicians in from the very beginning in the planning stages and have them be involved in the pilots and the testing.
Tom?
Yeah, I'm probably the wrong guy to ask this question because I'm a confirmed Luddite and I'm not great at assessing or being early adopter of technology. And, you know, I think that I think there are some of us like that, and there's some of us that are often very early adopters on the bleeding edge. And in my opinion, I think that I love the idea of the small group to help make those decisions. And I think you need a cross section of people like me and people who are at the bleeding edge. And ultimately, I think that you need to be embracing strategy and technology decisions with a purpose. And, you know, around technology, is it making our care more efficient? Is it making our patients' experiences better? Is it improving the interface with the technology for the clinicians? Is it making the clinicians' lives easier? I mean, there has to be a what and a why. And if there's not a what and a why, then why are we doing it? Technology for technology's sake is really, I think, compelling to many individuals. And I think you got to step back and say, why are we doing this? What benefit will be gained for whom and by when? And I think that is incredibly, I mean, you have to be able to get your elevator speech down. And if you can't create that elevator speech, if you can't create the compelling argument about why the strategy is important that we do this, or the technology move is doing that, then you're never going to be able to engage your physician, even if you have small groups and focus groups and all that, and you've got champions and all those other things we know that we need to do in order to get people to get on board and to be excited about something. You got to be able to be, you have to be able to tell the compelling story about the why and what's in it for them.
Great, Pat.
Yeah. So Tom, I love that. I'm probably the opposite side of the spectrum, having been in the tech space for most of my career. But I will also tell you, I agree 100%. Having people that will sort of push back is so incredibly important, because we, you know, using technology just because it can do something doesn't mean that we should do something. And being really sort of thoughtful about how we deploy resources in the current environment with technology is really important. That being said, I'll also say that the world changed, you know, 3 years ago, and our world is going to change dramatically with sort of the push in the AI space. And I've already mentioned it a couple of times with ambient AI. I think it's one of the things that is, you know, truly a game changer for providers. But being able to leverage technology now to do things that we couldn't do efficiently with technology 5 years ago. We might have been able to do it, but it really wasn't efficient. All the while being very mindful of and putting guardrails up around it, because it's a little scary in terms of what the technology can do. And I've seen some things, you know, that the tech can do that are sort of mind blowing. And, you know, we just have to be mindful about how we deploy them, I think, across systems. But I think there are going to be changes that are just massive in helping the efficiency and actually helping clinicians to be able to provide better care, take better care of the patients, and have more of the work-life integration or balance, whatever we want to call it, going forward.
Gonzalo?
Yeah, I think, I've talked a lot about how we involve the physicians very early. I was going to mention the AI, and so my colleagues beat me to it. That is something it's amazing, the ambient listening, what it can do and how it reduces the time. But there's also, patient privacy issues, concerns like that we all have about, how are we going to do this and do it in a way that makes sense? Radiologists want that. It's great. They interpreted the scan for you. That's getting to a little gray zone for us. So we have the physicians involved very early in those decisions, which I think is important, but also explaining the why is so important for the strategy piece of things. For example, we have 2 hospitals in the South that are budgeted to lose $40 million. Those are hospitals that are disproportional share hospitals. But when they see the new buildings going up in the North, you can imagine how they feel. Like, why are we building everything in the North and we're not getting new construction? And so we have our chief of staffs, our physician operating executives, looking at the finances, understanding that any normal business is not going to keep losing $40 million a year after year after year, unless we have strategies so that we can fund that. And so having physicians involved very early has literally, one of the hospitals that is not getting we're doing different things to make it look better, is not getting a brand new building. They have the highest employee engagement scores that we've ever seen, which is fascinating to me when they had to get the news that they weren't getting a new building. But it's how you explain it. And then we had physicians out there explaining to staff why they're not seeing a brand new building. It's critical to the organization and the culture that we have.
Excellent. What are some of the high impact strategies for investing in medical staff through operational innovations, such as effective clinical communications, through modernizing scheduling and on-call management? And Tom, why don't you start us off?
No, sure, Chris. Ask the Luddite about strategies for investing in operational innovation.
I was waiting for that, Tom.
Yeah. I think, my background is in quality improvement, and, I'll just take a page out of Six Sigma, which is, the whole goal here is to sort of narrow the processes. It doesn't really matter the outcome as long as the processes are completely controlled, because once the process is controlled, then you can move the outcome in any direction you want. Yeah. If you've got large variability, you're never going to get to an outcome that's with consistency or anything that you can dial in. And I think that lesson about quality improvement has taught, I think, and informed a lot of the way I think about much things. And I think that also matters with regard to innovation and communications, in that we gotta, in an organization as large as most of our organizations, you gotta be very clear about what are the ways you're going to communicate, what are the channels through which you bring ideas so that you can get to innovation. And there needs to be a consistency to how you do that. And there's a saying that I can't quite exactly remember, but there's a fine line between innovation and chaos. And if everybody's innovating all the time, then that's just chaos. But everyone understands how innovations happen and how they build towards change. I think that can be incredibly invigorating, enlightening, and improving for the organization. And it's a balance between that creative chaos, which could be just chaos on one side, and creative chaos that leads to true innovation and forward momentum. There's another saying that one of our fellow nutmeggers here in Connecticut said, Mark Twain. He would say things like, progress and innovation are great. It's change that I hate. But one can't happen without the other. And so I think one of the things you need to do in order to get operational innovation and better communications and all that stuff is to get everyone comfortable with change management. And that's harder than it sounds. And again, I'll just have to come back to our discussion around communication and why. Why are we doing this? None of us have enough capital to deploy in all the areas that is needed. Nobody has enough time. All of our patients are getting sicker and need more. All of the things that we are doing are becoming more expensive. And we got to be better at producing the why getting better with being comfortable with change, because change isn't change for change's sakes, but it's actually improvement, and being effective at communicating how that improvement has that compelling why. We are doing this for. And I think that those are really, no matter what you're doing, those are really important, thought processes to go through to get to those answers, so you can make that communication so that you can effectively ignite the normal baseline innovation we all have within our organizations, because we have honestly one of the most educated and creative workforces in any industry in the world. And tapping into that is so unbelievably important. And it's just have to be careful about how you do it, and how you're communicating the why about why you're doing it.
Pat?
Yeah, I echo that over and over. I think the thing that I've seen in my career, and you touched on it, is effective change management. When you're bringing in new tools and being able to explain the reason why, why are we changing this software system that I really liked and it was great for what I did, but having something across the system is great. Or why are we bringing in this software system for this one particular area, because it really answers the question for that particular area and we need to do it. So having that strategy and the governance, I kind of think of it out of the gate for those kind of, particularly around the technology sector, I think is really, really important. And we've been really successful from a company standpoint at doing that and deploying that so that we can answer the questions. Why are we putting in a system-wide on-call schedules? Because now everyone will be able to get a hold of everybody when you need to. You'll have a single source of truth we've talked about already. Those kind of things I think are really important, but managing the change, particularly, and we can all say this as clinicians, but as a physician, I'm not sure what it is about our training where we said you just need to be regimented and don't like anything that's new, until it's actually there, and then you can say, okay, that was great, thanks for doing that for me.
Isala?
I was just laughing about that, but thanks, Pat, for that. I'm going to touch on something Tom said, and that is operational innovation. You're absolutely right about chaos, and so we organize our thoughts and innovation around what we call the 6 R's, and it really focuses the entire organization. If you have great ideas, try and fit it into one of these buckets. So the first one is retaining staff. You all know how important that is, and how do you build that culture where people want to stay, even if the competitor is offering $2 more an hour, which is a big deal, but how do we want to keep them here? 2 is repatriation, which means bringing our patients back home. We have to know who's on call so we can accept those patients. But imagine you sign up for scripts and you end up in another hospital. How do we bring you home a lot sooner? It's not only good for patient experience, but it also, we pay a lot of out of network, right? Reducing costs. It's something we should all be thinking about, right? And working towards that. And how do we do the best at, do more for less, basically. Is what we work on. And then raise money through philanthropy is really important. Reducing length of stay. What are those ideas that you have that we can get throughput to? We actually leased skilled nursing facility beds during COVID because we could not place those patients anywhere else. And we've kept those beds to this day. And that helps throughput. So that's reducing length of stay. And the one I love the most is reassess and reimagine. Don't keep doing the same things over and over and over again. Think of something different that you can do. And the front lines are bringing in amazing ideas. Simply, here's one. You go to the lab, you have it on your app, you fill out all the questions, we still had paper forms. And imagine that's just annoyed me. Why am I filling out a paper form when I already have it on my app? And that's thousands and thousands of pieces of paper that no one even thought, twice about. That came from the front lines. Why don't we get rid of that? We got to create a culture where people are open to bringing ideas forward. The on-call management one is something we're all going to be facing. There's physician shortages. We have an aging physician population as well at some of our hospitals. And so we are literally working on a system-wide GI call coverage model, which I think is going to be a game changer for us, because we realize we're going to have issues in the north and issues in the south. But we can start putting this model together. To your point, Patrick, where there's one place you go to, who's on call for GI across the system. And you can get things done and not have to ship patients out of your network because you don't have somebody on call. That's going to happen with vascular, right? Cardiology, those are things that are coming down the pike here, ortho trauma. And so putting together a novel way of doing on-call. So GI is our first stab at it. We're going through the steps right now, so I have to follow up and let you know how it works. But it's pretty exciting to put that model together, right, and have a stable system in place. Otherwise, if something happens to one person on that call panel, it happened to me, some of you may know, I had a spinal cord injury, I'm out, and you have nobody to fill in that blank, then you're in trouble. So we're trying to build in some layers where we have some redundancy and availability, because things happen to people.
And Andy, we're almost running out of time here before we go to Q&A. I'm wondering if you can talk about modernizing schedule and on-call management.
Yeah, it's related to this question as well. And in the end, what we're after here is having physicians work at the top of their license and take care of patients. And having a scheduling system that works, that's simple, easy to use is part of that. The other piece that I wanted to mention is there need to be enough support staff in place to be able to manage the software solution, to enter the data, to monitor. The physician, him or herself, shouldn't have to be spending time working with the software solution. They should just be using it seamlessly, easily. So very important that it's set up in that way, and very important too that it's a single solution such that physicians working across different settings are able to use the same solution no matter where they work.
Great. Let me just skip forward here. First of all, thank you all for excellent discussion. This now brings us to the Q&A portion of the program. So we'd now like to invite you in the audience to ask live questions of our panelists. As a reminder, if you are participating in the live program, to submit a question, click on the Q&A widget at the bottom of your screen. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewed by other audience members. Let's see what we have here for questions. What do you want to see from your medical staff offices to support these initiatives that we've been talking about? And Pat, why don't you start us off?
Yeah, so I think from my standpoint, having been on credentials committees and so forth, and sort of getting an understanding of the critical nature of med staff and how it flows in through everything that we do. So having a credentialing product and a credentialing suite that works well both for the med staff office, but also for the clinicians. For example, when I was chair of our EM department, we had an old school credentialing product at the time, and it was basically a black box. So I would have people come in and they would go into the black box of credentialing, and then I would have no idea of where they would come out, where they were going to show up, when am I going to be able to put this person on the schedule. So having tools that give visibility for me as a leader in that process, also to the end user, and from our med staff, being able to look and see what our capacity is. Hey, I've got this person, they're going to come online in 2 weeks. I can start filling those clinic spaces, using that space more efficiently, beginning to get access for patients and generate revenue off of those docs. So having sort of that integrated connectivity with med staff offices and software solutions that work for that has been really, really important for us.
Anybody else want to chime in?
Oh, can I chime on to that? Oh, so go ahead. Oh, okay, go ahead. You mentioned the credentialing and privileging process. We had 5 hospitals, and initially when I came on board, they all had different privileging lists, and it was different proctoring. So imagine you go to one hospital and you have to have the cardiologist, be proctored for 5 cases. Then you go to another hospital and it's 25 cases. And you imagine if there's a lawsuit, we're going to be fighting amongst ourselves. Like, why do you have different criteria across the way? You can imagine what the lawyers will do with that. And so the medical staff offices have been critical in helping us standardize those bylaws, the privileging, proctoring, and all the things that you mentioned, Pat, as well. But the other thing that the medical staff offices can help us with is sharing the information about the initiatives, the checklists that we're generating, because sending an email to a division is not going to work. And I think we rely on the division chiefs to spread the information to their constituents is also difficult. And so the med staff office folks are all over the place, which is great. They're at the different meetings. They can help us spread the word. And I think that role is so critical to everything that we do. We need more messengers out there to reach those frontline docs. And everybody talks to the medical staff office. I don't know if you have candy or what you have in there, but everybody knows everybody really well there because they go and pop in, right? And so, hey, have you heard about this new initiative? And that has been really a game changer for us as well.
Anything else on medical staff offices supporting initiatives before we move on to probably our last question?
Just a couple of sentences, very similar. I was going to call the medical staff office the epicenter of communication. And some of that is outgoing communication, but the other side of that is incoming communication, really to listen and get feedback, because we might not be able to change the what or the why, but we could change the how and the when. We can pivot to try to make sure we're listening and our stakeholders are being cared for as best we can possibly do.
Excellent. Like I said, this is probably our last question. What recommendations do you have to keep nursing and providers cohesive throughout your organizations? And Tom, why don't you start us off?
Yeah, I think all of our strategies around communication, the compelling why, the shared mission about what we're doing, and what are our motivations around improving care for our patients and the experiences for all of our caregivers. I think all of those are central to creating cohesiveness between our care teams. And sure, it's the nurses and the doctors, but it's also the techs and the dietitians and the patient care technologists and everyone. Healthcare is, as everyone knows, it's an enormous team sport. And with any team, you're only as good as your weakest link. And communication among the caregivers and among all the different kinds of caregivers are incredibly important. So, I don't think there is one different strategy, but I think I think that it sort of weaves itself through the entirety of our conversation that we just had. It goes back to creating a compelling reason and then communicating that compelling reason and vision with absolute certainty and clarity. And then listening, because, there are, and although I'm sort of painting a picture of, kumbaya and everyone's here for the same reason, there are individual pain points and challenges and rocks in people's shoes in certain areas, certain job categories, and you got to listen for those. And you got to be able to rapidly turn around so that you build trust. And that you build trust that you're listening, and you build trust that you're trying to support the entire caregiver team, and that when there are challenges, you acknowledge them, you address them rapidly, and then you move on and you try to go to the next set of positive things, not just addressing the negatives.
That's all the time we have for questions today. In closing, please note that our next Winning Edge program on August 12 will cover the Winning Edge for Technology Investment. A live clickable link will appear at the close of this program, taking you to our registration page for the event. Remember to follow along all week for continued coverage on strengthening physician engagement and clinical efficiency by visiting our website, healthleadersmedia.com. I want to thank our panelists once again for an excellent discussion, and our sponsor, Qgenda, for making today's program possible. And finally, thank you to you and our audience for participating. We hope you enjoyed today's program and look forward to seeing you during our next Winning Edge program on technology investment.